All right, good morning, everybody. My name is Boris Chernobilsky. I'm going to be talking about state-of-the-art in diagnosis and treatment of obstructive sleep apnea. And one sec. And as you can see from this slide, I'm the director of sleep surgery. I'm a clinical assistant professor in both otolaryngology, head and neck surgery, and in the Department of Medicine at NYU Langone Health, which is in New York City. Hopefully you're going to enjoy this talk. We're going to start talking about, in general, what sleep is, very loosely, and then we're going to get into some common sleep disorders, and then heading into obstructive sleep apnea. And finally, we're going to talk about new diagnostic techniques and some new surgical techniques for obstructive sleep apnea. So what is sleep? Sleep is a complex behavioral and physiologic process. It's a reversible state of perceptual disengagement. In other words, you can go into sleep, you can get out of sleep. Most of us sleep with our eyes closed, but as you can remember from medical school, you perfected, sleeping with your eyes open during lecture. And it's also a state of behavioral quiescence. So you're basically not behaving in any way. Most of us are on our backs or on our sides. And it's divided into two distinct states, non-REM and REM. So rapid eye movement and non-rapid eye movement. And it's also controlled by the interaction of the exposure to sunlight and your own internal clock. That's called circadian rhythm. So we're on a 24-hour cycle, and it's affected by sunlight. So non-REM sleep, it's basically a period of EEG deactivation. We have slow wave sleep, wide complex waves. And then it's about 75 to 80% of our sleep time. It's divided into N1, N2, N3. N3 is what we call deep sleep. That's where we have those large delta waves. And the N1, N2 is significantly lighter sleep. So your arousal threshold when you're easiest to wake up is during N1, stage 1 sleep. And it's most difficult to wake somebody out of deep sleep at N3. So REM sleep, on the other hand, is your rapid eye movement stage. And it's actually a period of EEG activation. If you didn't know somebody was asleep, their EEG would look very similar, except for a couple of what we call sawtooth waves would look very similar to awake sleep. It's about 20 to 25% of your total sleep time. And this is the stage of sleep that's associated with dreaming. This is when we're dreaming and we're paralyzed. In tonic REM, it's mixed frequency EEG, it's suppression of muscle tone. This is when you have erection and clitoral enlargement and paralysis of the brainstem. So this is one way that people can test for impotence versus, whether it's psychological or physiologic impotence. And then there's phasic aspects. There's irregular breathing, muscle twitches, and conjugate eye movements. So what happens with aging? We have a lot more N1 sleep, lighter sleep. N3 starts to drop off, especially in men, and your sleep efficiency decreases. It's harder to sleep through the whole night, the full 8 hours as we get older. And there's also a slight decrease in REM. How much do we need? We need about 7.5 hours on average. Normal is considered between 7 and 9. People that need less sleep are called short sleepers. People that need more sleep are called long sleepers. Some people need 10 hours, Adolescents generally need 9 or more hours. And the elderly, 70 or older, need stable amounts of sleep. In other words, their sleep is fragmented. But as long as they get about 7 hours during total 24-hour period, they seem to be okay. There's high variability between individuals. Some people, like we talked about, short and long sleepers, and most of these things are genetically determined. And then there's a gender difference. Women need about 20 minutes more sleep than men. You have a lot of systemic changes during sleep, cardiovascular-wise. Our heart rate drops, our blood pressure drops, respiratory rate drops, our average oxygen level goes down, GI function decreases, renal function, you make less urine. That's why if you're having normal sleep, you're not running to the bathroom all the time because your urine output goes down, and you have temperature regulation. Endocrine function, mainly mediated through non-REM sleep. You have your growth hormone, TSH, insulin, and then ghrelin and leptin. And that's actually important because you get more insulin resistant and it suppresses your ghrelin and leptin. And those hormones mediate how hungry you are. So it becomes a vicious cycle in sleep states, in low sleep states like obstructive sleep apnea. Without those hormones, you actually end up being hungry and you eat more during the day, you gain weight, and then that becomes a vicious cycle because as you gain more weight, your obstructive sleep apnea tends to worsen, and it becomes a downward spiral. So what are some of the things that can go wrong in sleep? Well, everybody is familiar and probably has had a bout of insomnia. That's defined as difficulty falling asleep, staying asleep, waking too early, or having non-refreshing sleep. You need to have an adequate opportunity for sleep. So you need to have like a nice bed. It's got to be quiet. It's got to be dark. And then 30% of adults have symptoms of insomnia, and 7 to 10% meet criteria for a clinical diagnosis. Women are 1.5 to 2 times more likely to report insomnia. So what are the things that continue to cause insomnia? If you spend too much time in bed without sleeping, that you can get frustrated, you can get angry, it's going to be harder for you to fall asleep. Varying the time in and out of bed. In other words, you're sleeping 7 or 8 hours during the week because you have to work, and then you're partying all night on the weekend, so 3 to 4 hours on the weekend, and so you break up your sleep schedule. Not being able to predict your sleep if you're not sure when you're going to sleep. This is important in shift workers, doctors, right? When you're on call, you can't predict when you're going to get called by a patient. So that can cause, some insomnia. Worrying about things with daytime consequences, having too much caffeine. We generally don't recommend any caffeine after 3 p.m. And alcohol. Alcohol causes all kinds of problems. Basically, it suppresses breathing. As you know, it reduces your ADH, your antidiuretic hormone, so you end up peeing more, so you get up to urinate. And then also, if it's what caused you to fall asleep after you metabolize the alcohol, you're going to wake up as soon as it's out of your system, so it's going to fragment your sleep. So we don't really need to talk about these too much. Narcolepsy is an interesting disease. I always like to put it in because it's just so striking. It's basically a problem with orexin levels in your cerebral spinal fluid, and it's a problem with maintaining sleep or maintaining awake. In other words, sleep invades awake time, and awake invades sleep time. And so we use medicines to try to suppress REM and dreaming. This is basically a cool video that was posted by this YouTube user about cataplexy, which is something that is pathognomonic for narcolepsy. There's almost nothing else that will cause cataplexy. And cataplexy is when you have a state of extreme emotion. If you're super happy or super angry, it will cause proximal muscle weakness. It's not a sleep attack. Sleep attacks are where you just fall asleep. That can happen in any sleep-deprived state. But in narcolepsy, the weakness that you get for when you're excited is... So here you can see she's giving a video on exercise. She's excited, and then she has cataplexy. You can see she's not asleep, but she fell because she's got proximal muscle weakness. Her legs just gave out. And then she's going to have a sleep attack. This is where she falls asleep. Okay, so the cataplexy was very different than the actual sleep attack. Okay, so it's an interesting disease, and you should be aware of it. If somebody reports cataplexy, it's almost certainly narcolepsy. So then you have parasomnias, the confusional arousal, sleepwalking. That can be very complex. There have been cases of murder during sleepwalking and injury. There are night terrors. There are sexsomnias, REM behavior disorder, nightmares, sleep paralysis, sleep eating disorder. But that's not what we're mostly otolaryngologists, so we're not going to talk about these right now. So let's talk about snoring. So snoring is vibration of the nasal or oral airway. Mostly it's the palate. It's worse with your mouth is open when you have a increased flow, although some people can snore with their mouth closed. Those are harder to treat. It can be treated with various methods that overlap with obstructive sleep apnea syndrome. Most commonly used techniques for snoring are going to be nasal surgery. If somebody has nasal obstruction, they're going to want to open their mouth. And when they open their mouth, as you can imagine, the palate starts to vibrate more. Mandibular advancement devices that are made by the dentist are pretty good for controlling snoring. There's a technique called injection snoroplasty, which is where we inject a caustic agent submucosally into the palate. So typically our alcohol or sotradecocetol, which is what we use for vein injection for varicose veins. We basically inject a little bit under the mucosa, about 2 cc's. That causes a large ulcer, and when that sloughs and then scars subsequently, the palate is less likely to vibrate. And then, of course, uvular palatopharyngoplasty, various modifications of it. You don't want to be too aggressive if it's for snoring, are ways to stiffen the palate and prevent it from vibrating. Snoring, questionable whether it is of medical significance. It certainly can be very disturbing to a partner, or patients can wake themselves up with snoring. And there are several studies on carotid artery intimal thickening. And so potentially the vibration itself can cause thickening of the carotid and eventually carotid stenosis, which can lead to stroke. So there are some studies about snoring being not just benign and a nuisance, but actually can be lead to chronic life-threatening conditions. So let's get into the meat of it. What is obstructive sleep apnea syndrome? It affects about 4% of males, 2% of females, probably higher now in the United States as our obesity epidemic is increasing. And it's defined as the complete or partial obstruction of the airway during sleep, right? Obstructive sleep apnea does not happen. The actual obstructions do not happen during awake time. Okay, and usually causes a decrease in oxygen saturation and usually ends with a brief arousal. So you wake up, and you can wake up, 40, 50 times an hour, but you don't really remember these because everybody has hypnagogic and hypnopompic amnesia, which is you don't remember a few minutes before and after you wake up. And that's why we don't remember our dreams in general. And so somebody can wake up 50, 60 times an hour and just wake up tired. They don't remember that they woke up. And we measure this in apnea and hypopnea index, AHI. If you're going to be looking at severity, we're looking at AHI. So what is AHI? Those are the apneas and hypopneas that are happening throughout the night, divided by the total sleep time in hours. And so that's what it goes. Obstructive sleep apnea risk factors: a 17-inch neck. Sorry, I don't know it in centimeters for you guys, but you can convert the 17-inch neck in men, 17-inch neck in women. Obesity, it's much higher if your BMI is over 35. Patients with congestive heart failure are likely to have sleep apnea. Atrial fibrillation can be caused by the oxygen desaturation. And very importantly, if somebody's had an ablation, they are more likely to recur if they've had AFib. Refractory hypertension, somebody's on 3 blood pressure drugs and you're not sure why, you have to look for obstructive sleep apnea. Type 2 diabetes, we talked about the insulin resistance earlier. You have nocturnal dysrhythmia, stroke, pulmonary hypertension, high-risk driving populations. You have to be aware of obstructive sleep apnea. Truck drivers, a lot of our disasters have been due to just people falling asleep behind the wheel. The Exxon Valdez disaster, if you recall, was the captain falling asleep. We've had Amtrak problems. And it's very important to screen as pre-op for bariatric surgery because we need to know how to treat them perioperatively. So what are the symptoms of obstructive sleep apnea? Unrefreshing sleep. Somebody says, oh, I slept 9 hours, but I feel exhausted. They wake up, they have a morning headache, they have dry mouth. Driving, you have to be careful. If somebody's had a lot of motor vehicle accidents, they're 2 to 3 more times likely to have a motor vehicle accident. And usually it's actually a low speed accident. When people are sleepy, it's not so much when they're active. All of us have been on call. All of us have taken, 24-hour shifts, 36-hour shifts, and we're able to function and operate. It's not when you're in the emergency. It's not when you're active. It's when you're finally sit down to take a rest and relax. That's when you fall asleep. And so you can imagine if you're stopped at a red light and you're extremely sleep deprived, that's when you're likely to fall asleep. That's when you're likely to take your foot off the brake pedal and crash into the guy in front of you or woman in front of you. Sex problems, cognitive memory issues, and nocturia, reflux, sweating, and insomnia. So women are more likely to complain of insomnia with obstructive sleep apnea rather than fatigue. How do we test for this? We test with a polysomnogram. Most of our polysomnograms are 12 12 leads. We have our EEG leads, we have our EMG leads, we have our effort belts, we have a pulse oximetry, and then we have flow monitoring. So altogether, a standard polysomnogram is going to be 12 leads. So anatomy of the airway, you're all familiar with this. We're going to go quickly. The air's got to go from your nose or your mouth into your trachea. So because of our evolution and because of the way that our structure has evolved, we can have problems anywhere along the pathway. We can have a problem with the nose. So you can have nasal valve obstruction at the opening. You can have turbinate hypertrophy in the nose. You can have a deviated septum. This is a sagittal cut, so obviously you don't see the septum. You can have a significant problem with the adenoids. This is more of a problem in children, but in adults, I have had several cases, even in obese patients, where we've had complete obstruction of the adenoid, and removal has, completely cured it. Palatal enlargement, you can see that obstructs this area of the nasopharynx. You can have tongue-based obstruction at the oropharynx, and then the epiglottis can collapse. If I had a axial, it would also be potentially the lateral walls could be an issue. And this is just a sort of a loose diagram. This is, what we call normal, and you can abnormal. You can see the difference in the palatal thickness or the tongue base. You can see that as the pharyngeal space narrows, you can imagine laying down on your back supine and having low muscle tone, you're going to have obstruction. Similarly, on a coronal view, you can see the large tonsils, large uvula, higher tongue base are going to be an issue. So what's the gold standard for treatment? Gold standard for treatment is positive airway pressure therapy. You can have a full face mask, nasal pillows, just a nasal mask. And this is one of the new masks. It's a DreamWear mask. I really like it. Patients don't have as much claustrophobia with it. The hose is out of their face. And it's a nice mask made by Philips. Respironics now makes a similar mask. And it's really good. Nothing is better than positive airway pressure, but in the treatment of obstructive sleep apnea, but only about 30% of patients will tolerate it for more than a year. And so we have to have alternatives for these patients. So what are the things we can do? We can do nasal surgery. These are important adjunct medical therapies. Some of the techniques that we use are septoplasty, nasal valve repair, turbinate reduction techniques, adenoidectomy, polypectomy, and certainly if somebody's got a tumor of the nasal cavity, that's something that we're going to want to take care of. Oropharyngeal surgeries include tonsillectomy, uvulopalatal-pharyngoplasty, and these are your traditional uvulopalatal-pharyngoplasty, which is usually removing the tonsils as well as the part of the palate and uvula. There are Z palatoplasties, mucosal advancement palatal, and all kinds of different modifications. The one that I want to talk about today is, we'll go through some of the other techniques, and then we'll concentrate on specific techniques as we move on. Hypopharyngeal procedures are going to be suspension procedures like genioglossus advancement, which is basically taking the cortex of your mandible, taking a window, pulling it forward. I don't particularly like this technique. You can damage the tooth roots, and you're only getting a couple of millimeters because that's the cortical width of the mandible. There are techniques including the tongue-based suspension and high rate advancement. And then there's volumetric reduction. So lingual tonsillectomy, smile procedures, which are removing parts of the tongue submucosally, usually using coblation, and then transoral robotic surgery, tongue-based reduction. Global procedures, which affect every level, are going to be mandible maxillary advancement, tracheostomy. Is that our gold standard for ENT because we're bypassing the whole airway, and then hypoglossal nerve stimulators. So adenoidectomy, you're all familiar with it. It's basically an enlargement of the adenoid. It's going to obstruct the palate here, and it's a very powerful technique. If somebody's got 4+ adenoids, you're going to cure them most of the time, unless they're morbidly obese. So this is typically done in children. Pharyngeal obstruction, with the palate, tongue, tonsil. This again is done frequently in children, a tonsillectomy. And the traditional one is basically removing the tonsils and cutting it all the way across and basically making a wedge. When you evaluate for pharyngeal surgery, we use the Friedman scale, and that's a combination of their tongue position. So Friedman 1, you can see the whole pharynx. 2, you can see about 50% of it. 3, you see just the base of the soft palate. And then Friedman type 4 is going to be the entire hard palate is going to be difficult to see. Tonsil size, so 0, somebody's been operated on. 1 is it's within the pillar. 2, it's to the pillar. 3, it's past 50% of the pharyngeal space. And then kissing tonsils are type 4. So tonsillectomy, we also all know, you have these big tonsils. You can see this guy is a type 1, right? He's not quite to the pillar. This is a type 3 on this side. It's just past it. After tonsillectomy, you see the nice scar. You see the airway is a little bit more open. This is a traditional uvulopalatopharyngoplasty. I do not love these. Part of the problem that happens here is that there's no uvula. When I operate, I don't like to cut off the uvula completely. I like to shorten it. I feel like this causes a shelf in the back of the nose. And so all of the mucus, we make about 2 liters of mucus a day. And so I feel like if you have this shelf here, it collects. And so you're going to cause a lot of globus sensation. The patient's going to, they're going to be sitting there snorting, trying to get rid of that mucus. So I always like to leave a little bit of tapering of the uvula so that they can easily swallow the mucus that's being produced in the nose. But this is basically the traditional pharyngoplasty. And the other problem is because you have one line here, it causes contraction of the pillars. So I've seen it where, you have just like a V here, and you've actually made them worse because you've narrowed their pharyngeal pillars. So I don't love this technique. You can still do it safely and well, but you have to be mindful of the fact that you should probably leave a little bit of uvula, and you should probably break up the scar in such a way that you don't get this horizontal contraction that can worsen their sleep apnea. So this is my workhorse. This is what I do most of the time for my pharyngeal procedures. You can do a tonsillectomy. This is called an expansion sphincter palatoplasty. Kenny Pang and Tucker Woodson originally started. It's based off the concept of a cleft palate repair, where we take the palatopharyngeus muscle and repair the palate by swinging them 90 degrees. But instead, what we're going to do is we're going to take the tonsil out. We're going to divide the palatopharyngeus muscle here. We're going to make a muscle flap, and we're going to flip it 180 degrees. And this technique's been modified. We no longer make an incision here. I make an incision just over the hamulus, and then I make a tunnel. And so then I put a couple of vicral sutures, and then I bring this up and forward. And so what that does is that expands the palate, expands the palate forward and laterally. And so the whole palate comes forward and expands. I also, Kenny Pang, he's in Singapore. He doesn't like uvulas because it's nice and humid and warm there, but I always leave the uvula. I don't cut it off like he does. Sorry. And so you get a nice expansion. The other nice thing about this is you haven't touched any of the muscles of the palate. You haven't damaged the palate of the tensor veli palatini or the levator veli palatini. And so they're much less likely to get velopharyngeal insufficiency. So the risk of complications after this surgery that are common with uvulopalatopharyngoplasty are significantly reduced. So something that is gaining a lot of popularity in Europe and the United States is something called, actually started first in Europe with De Vries and his colleagues in Holland, is something called drug-induced sleep endoscopy. And what we do here is we use medicine to induce a state of sleep we don't want to obviously over sedate them, but we want to get them snoring and obstructing like they would normally. So what are the techniques? There's arguments over what the best agents are. So there's Versed or midazolam, there's Diprivan, which is propofol, and there's dexmedetomidine, which is Precedex. And most of us don't use Versed. Versed is a benzodiazepine. The nice thing about it's all very, very short acting, but it does cause a significant amount of respiratory depression and and oxygen drop. So it's not great. Propofol is nice. It's the one that I use. We use a targeted protocol, and I like it because it's very quick on and off. It does cause a little bit of a blood pressure drop, and it does cause a little bit of respiratory depression, but it's exactly kind of what you would get during sleep. One problem with propofol, it is very REM suppressing. So if somebody's primarily has REM, sleep disordered breathing, are we really getting what we need here? I don't know, but it's the technique that I use. Other people like Precedex, especially in children. The nice thing about Precedex, it's a dissociative agent similar to ketamine, but and there's no respiratory depression, so it's not exactly like sleep, but it's a very safe drug and very easy to use. So the majority of people are going to use these two drugs. In adults, people tend to use propofol. In children, we tend to use Precedex. So does it make any difference in planning? Well, there's definitely studies that show that it does. 64% of patients that had a DICE or sleep endoscopy had a different recommendation for surgery than they did if just based on a clinical exam. The only thing that your clinical exam and your DICE will agree on are tonsil size, right? Tonsil size does not change whether you're asleep and awake. So you can always agree that big tonsils are big tonsils. But beyond that, how much contribution we have from palate, how much contribution we have from the sidewall, how much contribution from tongue base or epiglottis, you don't always have between your awake exam, which is full muscle tone, and the DICE. So how do we grade it? This is a scale made by Eric Kazarian. This is the VOTE classification. It talks about the site, the degree of narrowing, and the configuration of obstruction. There are different scales, but this is the one that I like to use. And it's called VOTE as velum, oropharynx, tongue base, epiglottis. And then at each site, is there how much obstruction? There is none, partial, complete, or is it AP, lateral, or concentric? So here are pictures of the velum. This is out of De Vries's book from Operative Techniques in Head and Neck Surgery. Here we have an open nasopharynx. You can see this bulge is the uvula muscle. This is at the level of the velum, the nasopharynx. This is the posterior pharyngeal wall. These are the lateral walls. And so here, this is a partial antero-posterior collapse. You can see that the right side is completely collapsed. The uvula is touching the back wall. We've got a little bit of airway, and this is it open. So this is a partial AP collapse. This would be a complete AP collapse. You can see here's a hypertrophied uvula muscle, and this is completely obstructed. And this is what we call circumferential collapse, or a sphincteric collapse. And you can see the sidewalls, everything is kind of collapsing. And this is actually unfavorable for hypoglossal nerve stimulation. So in order to get a hypoglossal nerve stimulator, everybody gets a DICE. And if we see this kind of collapse, they're excluded as a candidate. In the oropharynx, this is normal. We have our larynx, we have our epiglottis, we have our uvula, and this is going to be a lateral collapse. This is going to be the side walls are coming in and causing a problem. This is the view of the tonsils, and then this is obviously their view awake. So you can see that on DICE, this view with lateral collapse is going to agree with this awake exam. Tongue base collapse, you've got your epiglottis, your tongue base, the airways open, and then this is a complete AP collapse. You can see the tongue base and epiglottis are plastered along the back wall, and then this is a partial. You can see there's a little bit of airway, and then the other interesting thing about this one is that this patient has huge lingual tonsils. So we don't have a good grading scale for lingual tonsils, but I'm sure Michael Friedman's working on that. And then, of course, epiglottic collapse. You can have isolated epiglottic collapse. This is really hard to treat. It's controversial. We don't have good studies on it. But you can see this is kind of a ball valving of the epiglottis against the back wall. And you can see the tongue, it's independent of the tongue. The tongue is forward, and the epiglottis is curving backward. You can also have concentric collapse of the epiglottis. This is going to be more of a, like a laryngomalacia in a pediatric patient. This, however, is something that I will typically see in adults, and this is usually with morbid obesity because the sidewalls are compressing with every breath, not every breath, but every obstruction. I think the uvula probably remodels. I don't think this is a genetic variant. I think that this is acquired by years of pressure. So this is one of my patients on DICE. I just want to show you, this is something that you'll never pick up on an awake exam because they have muscle tone. But you can see this patient, their tongue is fine, but you can see that their uvula, I mean, their epiglottis is just ball valving down. And with every breath, it gets worse and worse. And also, you can imagine that this is a patient when their epiglottis is down is going to actually do poorly with CPAP because when that epiglottis is pushed against the wall and now you've got positive pressure, it's actually going to push that epiglottis in more. So it's difficult to say what's going to be best for this patient because their tongue is forward and it's completely separated from the epiglottis. So our gold standard, like how we can 100% cure these patients in ENT is with a tracheotomy. Sometimes that's necessary. You're bypassing the entire airway. You have a morbidly obese patient with a BMI of 40 or 50. They're gonna, pharyngeal surgery is not a great option for them. So, and you need to fix them, right? I mean, there's somebody who might be falling asleep awake or have obesity, hypoventilation syndrome. A trach is reversible. These are, old school trachs. You probably still have these guys. We use all kinds of silastic, or you probably have, do you guys have the silastic ones? I'm sure you do. You can see the cuffless fenestrated. We have the cuffed, and then we have the laryngectomy tubes. This is actually a really fantastic trach. This is called a Montgomery long-term cannula, and this is a short-term cannula. You can see that the only part here in the airway is this little flange. There is no other component in the trachea, so that's incredibly comfortable to use, to wear. And you can see it's incredibly well tolerated. You can cap it, and so you can wear a shirt with it. You can swim. You're fine. And then at night you just uncap it, and your sleep apnea is gone. So let's talk a little bit now about the newest thing and hottest thing in, at least in the United States and some countries in Europe, like Germany, is hypoglossal nerve stimulation. This started out in the STAR trial in 2014, and it's was in the New England Journal of Medicine. This is called, the company that makes this is called Inspire Sleep, and it's basically a device that works fully implanted inside the body. It monitors sleep patterns during breathing during sleep, and it gives stimulation to the hypoglossal nerve, and it's activated with a remote. So the surgery basically has been modified. It used to be 3 incisions. It used to be an incision here under the mandible, and then under the clavicle. This is a little high. It would be normally here. And then we had a 3rd incision in the 4th or 5th intercostal space. What we have now is 2 incisions. We still have this incision. And when we have this incision, what we do is, we basically make an incision down through the platysma, and then we identify the digastric muscle, put a loop around it, retract it inferiorly. Then we identify the submandibular gland and retract it posterior superiorly, and then the mylohyoid. And that actually puts you right down on the hypoglossal nerve. We're not finding the whole nerve. We are now then go under the microscope, and then we dissect out just the branches of the nerve that protrude the tongue. Okay, we don't want any retractor muscles. And so once we identify that, we put a cuff, a 3-electrode cuff, which is called a stimulation lead, around the C1 and just the protruser branches. And we are actually testing, we're monitoring because we have leads in the tongue during the surgery, which tell us which nerve is part of the hypoglossal nerve is being activated. Then we have a second incision. We split the pec muscle bluntly, and we dissect down onto the chest. And then we find the external intercostal muscles in the second rib space. And then we place the sensor lead between the external and intercostal muscles. And then it has the sensor probe is facing the chest. So what it's doing is checking for decreases in intrathoracic pressure. So then it generates an algorithm. So anytime you breathe, it causes the tongue to come forward, clearing your airway. And patients get a remote. They can adjust the stimulation daily and increase it as necessary. And so what we do is we just slowly increase the stimulation until we have enough energy and voltage to bring the tongue base forward. So how effective is it? So this is from the STAR trial. It's pretty effective. Remember that unlike CPAP or PAP therapy, surgical success is basically a 50% reduction in the apnea-hypopnea index and under 20. So what we're trying to do with surgery is get them out of that severe range, out of the range that they have a risk for heart attack and stroke. We almost never get them below 5. We don't usually get them to normal, especially if they're obese, but we want to get them better. And so you can see that on average, there's a 68% reduction in your AHI. At baseline, it's 29, and then it goes down to 9 at month 12, and it's sustained. And then it's a 70% reduction in the oxygen desaturation index. Significant improvement in the FOSQ in the daily functioning. They go down from 11 to 6, so it's normal range. And in the Epworth sleep scale and the FOSQ goes up to normal. So from 14.6 to 18, which is normal functioning. For the partners, this is very important. There's an 85% improvement in snoring, where the partner is no longer complaining of their the snoring. And then this is basically in vivo how this device works. So with the velar pharynx off, and with the device off at the velar pharynx, you can see that it's completely obstructed at the level of the nasopharynx. And you can see at the tongue base, we have this little opening. And you can see with breathing, there's significant collapse here. So this is what happens there. So when you turn the stimulator on in the same exact patient, you're going to see basically a mechanical pop where the stimulator turns on. So off and then on. So how successful these things are generally is how well the pharynx is coupled to the tongue base and here this is the tongue with activation of the hypoglossal nerve stimulator. So you see it just pops forward with the breath, pops forward, clearing the airway. So it's a very powerful device and technique. How long does it last? Well, you can see there's a significant, outcome at 3 years. This has improved because obviously some of our patients fell off, but still you can see that the apnea-hypopnea index at year 1 to year 3, and now that we have 6-year data, shows that there is a consistent efficacy of the device. You can see the compliance is fantastic. This is where it's so powerful. This is much more compliant than CPAP, where you only have about 30% compliance at 12 months. You can see that here we have 87% compliance at 3 years. And, the STAR trial follow-up, same thing, 5-year data. And you don't need my contact info. That's the lobby at NYU, which is really nice. So that's sort of sleep apnea, and some of the newer techniques in a nutshell. I'm happy to take questions if you want. So
Thank you very much. Maybe you have some questions? Very interesting, really interesting lecture. Thank you. And yeah, we have a question, Boris.
Sure.
Hello, Boris. Hi. I'm glad to see you.
Good to see you.
I have two questions. What is the favorite procedure for the therapy? I know that you have the best one is the stimulation, but what very often another treatment are you doing in another case? It's a Z-plasty or it's a uvula palatina or another one. What the second one after the stimulation and the third one after the stimulation I used often?
Yeah, so it depends, it depends on where the site of obstruction is. If it's, if we're talking about at the level of the pharynx, I like to use the expansion technique that I showed you. If I see circumferential collapse or lateral wall collapse, I will use the expansion sphincter palatoplasty. That's powerful because it removes the pillars and pulls them upwards. So that was that expansion technique that I showed. Hold on. Where is that? All right. So that's going to be this one, so if this debulks the lateral pharyngeal wall, and then it's used as a lever, and we pull it up here and anchor it to the bone of the hard palate. And when you pull on that actually lateralizes your wall this way and pulls your palate anteriorly. It's a very powerful technique. It's not that difficult. And you just want to get this muscle off of the superior constrictor. This is if you're going to be doing any kind of pharyngeal work, you should learn this technique. It's not that difficult. The risks are lower. It doesn't cause as much velopharyngeal insufficiency as traditional uvulopalatopharyngoplasty, and it's just incredibly powerful. I love it. This is my go-to, my bread and butter, like pharynx procedure. If I feel like the lateral walls are okay and it's just more of a anterior posterior collapse, what I'll do is, it's sort of a modification of a mucosal advancement surgery. I will take a 1 centimeter oval out of the pharynx above the uvula. And then what I'll do is I will actually take about 1 centimeter of uvula muscle. I'll dissect it out centrally under the levator muscles, and then shorten the uvula this way. So I do a horizontal mattress, and then I'll suture this tight. And so that just advances the palate forward. And it's very nice. That's something where we don't really need to touch the lateral walls like on a skinnier patient, where you've seen that it's purely anterior posterior collapse on the dice rather than more of a circumferential sideways collapse. So those are my two go-tos for palatal procedures. I'm spoiled. I don't love any other major techniques for the hypopharynx. I feel like they're painful. They're higher risk because of lingual artery problems. There have been deaths associated with hypopharyngeal surgery. But Claudio Vancini, in Italy near you guys, and Erica Thaler at Penn, they're very big on robotic tongue-based surgery. So you can use lingual tonsillectomy or tongue-based reduction if you have somebody with a very bulky hypopharynx, if you don't have access to hypoglossal nerve stimulation. And then actually I like the hyoid suspension procedure. We have something called airlift in the United States. It's basically putting 2 screws under the mandible, and then you dissect the hyoid bone, and then you can put a couple of sutures around the hyoid and pull everything forward. And so what that does is that opens that retrolingual space. The downside to that is it's on the mandible. And so if somebody opens their mouth, you lose that suspension, but then you can use an oral appliance or a chin strap, and that keeps everything forward. So those are sort of like my go-tos that you can do if you don't have access to hypoglossal nerve stimulation. Like what I'm trying to tell you guys is that you can't do the same thing for every patient. It's very important to learn how to do a DICE as well. That's an easy procedure to do. And that's going to help you direct what surgery you're going to pick for them. If you're going to do just a palate on everybody, you're going to have a 50% failure rate. Okay, because that's not what everybody has. And that's what happened in the 80s in America, is that everybody started doing palates on everybody, and we had only 50% success. And so the pulmonologist looked at us like we're idiots, because, a 50-50 shot and giving somebody a painful surgery, it's not ideal.
And one small question: are you doing the operation without DICE?
Yeah, if it's
Without-
if it's obvious, like somebody's like, I have an adult with big tonsils, big pillars, a really long uvula, that's gonna help them no matter what, but I counsel all of them that if they're obese or that they still have some symptoms, then we might do a DICE afterwards, so like if if somebody's got 3+ tonsils, large pillar, long uvula, they're going to be helped by a U-triple-P. They're going to be helped by this procedure. I don't need to do a DICE on them, but I tell them they might need a DICE after if they have any residual sleep apnea, because we don't often cure them completely, especially if they're overweight. In the United States, we have a huge obesity problem, so just doing a palate doesn't always fix them.
I see if you look at the patient and see the big problem, you can operate without the DICE. Okay?
100%.
And if you have no answer on this sleep apnea, all of parts of your body in the throat, nose, good, but sleep apnea present in patients, that's why you use the DICE, yes?
Yeah, so if it's completely obvious, like, so I would say like 25% of the time I'm going to look in the mouth and I'm like, I can fix this, about 25%. I'm like, I love it. You're going to be better. We don't need to do a DICE. Let's just go to surgery. I would say, 70% of the time you're not sure, like if somebody's a little overweight, their tonsils are like medium, like if I looked at you and I examined you, I would want to do a DICE, because I'm not going to be 100% sure. You know what I mean? Unless I looked in your throat and you had huge tonsils or a really long uvula that's sticking down, touching your epiglottis, but like for a lot of patients, you're not sure how that muscle tone works. You'd be surprised how much of, especially in middle-aged men, I see like, 30% of your patients that have obstructive sleep apnea are thin. Right? For them, a lot of it is going to be positional and REM related. Their muscle tone is low, and it's going to be supine. So they're doing this, so they're not getting that big lateral collapse. It's not their palate. It's going to be potentially their hypopharynx. And if you just operate on them, you're probably not going to do well, because their problem is more muscle tone rather than soft tissue.
And the last two questions: are you doing not the reduce the base of tongue, but drill the mandibula, take off from the mandibula and cross?
Yeah, I mentioned that earlier. I hate that procedure. I've been an expert witness on some lawsuits because of that procedure. The problem with it is that, you can hit the tooth roots, right? So if you hit the tooth roots, you're going to lose your teeth. The other problem is that you can destabilize the entire tongue, especially if you have any necrosis, or if and then what happens is they can have speech problems. I had a GI doctor that had this done, not by me, but that consulted me because of speech problems. They had difficulty doing their job and counseling patients afterwards. And then remember, we're only getting about, 2 to 3 centimeters, depending on the thickness of your cortex, right? We're doing a full thickness cortex. So if you've got somebody with really thick mandible, you know, what is that, 5-6 millimeters? You know, you're pulling that forward. But then remember, it's attached to muscle, so that's your genioglossus muscle. So now you've got a year of them on their back. That muscle is going to stretch out. I don't really like, you know, I don't think there's that much longevity to that procedure. You know, so it's high risk, and I think that it doesn't last.
Okay, thank you, Boris, for the good presentation. And we want to see the operation, what are you doing with this tongue, palatin, and other part of the throat and hypopharynx. If you can show us in a presentation, another one maybe in the future, or maybe the YouTube channel where you have this operation, and we're glad to see this operation.
Sure.
What are you doing?
Okay, I'll torture a resident to hold the camera still for an hour. No problem.
One more question from our auditorium.
One more question.
Sure.
В тому кейсі, що він показував з надгортанником, яку тактику він використовував? Я можу послухати. Трахеотомію, так. Резинки надгортанника не робили нічого, так?
One more question. Okay, Boris, thank you very much. We know that you are in London now and you have weekend. And thank you very much for your time.
Yeah, of course.
It's much appreciated that you give us so nice lecture. Thank you, Boris. Thank you.
Yeah, of course. My pleasure. Stay safe, everybody.
And thank you. Thank you. Have a nice weekend. Have a
Thank
nice
you.
weekend.
You
Thank you.
too.